So I'm going to take the first 5 or 6 minutes of our time together and first start with giving you a little bit of a history lesson. So let's make sure we're all starting from the same place and go back in time to way back in October of 2012 when the hospital readmissions reduction program first came out. And what happened, Medicare came out with the plan to do financial penalties for hospitals that had excessive 30-day readmissions. And they did it in a phased approach. The first year, there were 3 conditions that hospitals could receive a penalty for, and it was for acute myocardial infarctions, cardiovascular disease, and pneumonia. And then the next year, there were additional conditions added, including COPD. And as you recall, that there was also the penalty was gradual each year. So in fiscal year 13, hospitals could be penalized up to 1%, fiscal year 14, 2%, and then when COPD was added in fiscal year 15, hospitals could be penalized up to 3%. Now, this was not 3% of their Medicare payments for COPD. It would be 3% of all Medicare payments across the board that those hospitals would have withheld. So all of a sudden, those penalties were millions and millions of dollars, really prioritizing the issue of hospital readmissions very, very quickly. Next slide, please. All of this is grounded in the report that came out, 16 years ago by AHRQ. And let me talk you through this just real briefly. What we found out is over time, a variety of health conditions had reoccurring readmissions, COPD being one of them. And so if we look at this chart, what we found in this report is that patients with COPD readmitted frequently. So if you look at the middle column, what we found is that for patients that had COPD as their principal diagnosis, they would readmit 7.1% of the time within 30 days for COPD again as that primary issue. But when we started looking at a little broader and saying for patients that were there for COPD and they came back for COPD at any diagnosis, any point in the diagnosis, about 17% of them were readmitting. And again, notice that next row where every time we got that readmission diagnosis a little bit broader, the price tag went up too. And then if we looked on the far right, when we looked at the 30-day readmission for all cause, so the patient was originally there for COPD, we sent them home, and they came back within 30 days for any reason, what we found is the 20.5% of those patients came back again. And it was costing us a minimum of $11,100 for that readmission. So this was in 2008 dollars. You get the idea. This was expensive. 1 out of 5 patients was coming back again within 30 days. So on the next slide, we're looking at this, slicing it a little bit differently. So what we were looking at is for those patients with COPD at the original diagnosis, and they came back again within 30 days, why'd they come back? And what research over time was telling us is this third bar here, is that a third of the patients came back because of their COPD, but 64% of the patients came back for a different reason. And so the research was pointing us to that when the patient was originally there for COPD, we were missing something. We were not looking at the patient as a whole patient. We were only addressing their COPD, and we were missing other potential comorbid conditions or health disparities that cause them to come back again. So really pointed to us that we needed to think about COPD readmission prevention in a very broad perspective. So on the next slide, um, thank you, Ricky, talks about interventions that have been happening over the last dozen years, really to reduce these unplanned readmissions. And I have to tell you, we haven't made a lot of progress. There have been some stellar programs that have been developed to address and prevent COPD readmissions, but as a country, we have not significantly moved that needle to reduce unplanned readmissions. But what we do know is of the programs that have made some success, there are some key points in there. And so I'm going to just list them off for you. And then I'm going to turn it over to Ricky because we've invited one program from Georgetown to talk about their current and newly developed COPD readmission program and how they're addressing this topic today. So these interventions, we know there's some common elements to be successful. We need to really think about supportive documentation processes in our electronic medical record. Number two, this one's really important. We need to be able to not just give the same program to every patient with COPD, but we really need to stratify our patients when they're in the hospital for a COPD inpatient the first time. We really need to identify those based on data who are at greatest risk for returning again. And instead of giving a cookie cutter and everybody everything, we really need to stratify that risk. We need to partner with the patient and collaborate across the disciplines to make sure that everybody is involved in helping this patient. We need to provide evidence-based inpatient and outpatient care, help the patient develop self-management skills while they're in the hospital and when they go home, reconcile medications to make sure that the medications they are on are focused on preventing future exacerbations. We need to deal with appropriate discharge instructions, have timely follow-up with the patients, including home visits. We need to communicate, refer to pulmonary rehab, and then we need to measure our outcomes to see if we're making a difference. And if we're not making a difference, we need to do something different to make sure that we're serving these patients with COPD the best we can.